are going to go ahead and get started. I have the privilege of introducing our next speaker. She asked me not to embarrass her, so I will try not to. Peggy Knudson is going to talk to us today about the CLOTT Consortium. Dr. Knudson is Emeritus Professor of Surgery from UCSF, and most importantly, works mostly in this building now with military trauma and military-civilian collaboration in trauma, and has run the CLOTT Consortium for a few years, and we're going to hear a lot about it. Peggy, the floor is yours.
I really appreciate being part of this conference and seeing all these excellent talks that have already been given, and really the enthusiasm for all of you who are here to want to learn more about it and continue on in the research. I was just relating that, one of the reasons I became interested in this was around the same time that Dr. Gertz was becoming interested in it, because a patient of mine who I nursed through a liver injury and a chest injury and multiple other injuries and on a ventilator for a long period of time, stood up in front of me and his wife when we found out about the ventilator and dropped dead of a pulmonary embolism. And I was very early on in my career as an attending surgeon, and I was devastated. And I went to the literature and said, what the hell are we supposed to be doing to prevent this in trauma? And I pulled out that same NIH paper, which is all there was. And about that time, it said, oh, yeah, some of the patients are at high risk, but we don't know what to do with them. So that became my introduction to this world of research in this particular field. And I've had the great fortune of being able to continue on with this for, I'm not going to tell you how many years, but a lot. So today I'm going to talk a little bit about CLOTT. CLOTT is funded by the Department of Defense. And we have really a number of co-investigators who are in this room, which I really appreciate because there's been a lot of work that has gone into this. Okay, what am I supposed to press? Oh, no, sorry. Did I do that or did you do that? Let me try it again. I'm not doing anything. Oh, my goodness. Oh, my goodness. All right, can you go, bring it all the way back? That's the first slide? What is going on? All right, let me try it again. Wait, it's really slow. All right, so what is CLOTT? All of us, particularly the people who are in the military, have to have, some kind of an abbreviation for everything. So this actually was from Steve Shackford, who called it the Coalition of Leaders in the Study of Traumatic Thromboembolisms. It wasn't that I couldn't spell CLOTT. It was really CLOTT. And it was initiated through a meeting at the AAST in 2013. And a group of surgeons, many of them in this room, who thought that we were experts and had an interest in publications or research in the field of VTE after injury got together. And we first talked about how we all practiced, and we did a survey of all of the ways we practice in preventing VTE. And just like the discussion in this room, we all practice differently. And so we actually published a paper called Variance is the Norm. So even though we thought we were experts, we were all practicing a little bit differently. The second publication, which also was alluded to earlier, was a prospective study that showed that if you screen people, the chances of you finding CLOTT was 5 times more than if you didn't screen. And so what was brought up about the quality and the metrics, we were able to actually show this. And we did that without any particular funding. I don't know, you guys are going to be tired of me if we have to do this each time. So the major paper that has come out of CLOTT well, let me go backwards. So at American Surgical a few years ago, based on NTDB data, we looked at almost 4,000 post-traumatic pulmonary emboli. And as we searched through the data, we suggested that perhaps there was a disconnection between DVT and PE, and that we suggested going out on a limb that pulmonary clots might be more inflammatory rather than embolic. And then as you go back through the literature, we'll see that George Belmahos at Harvard had actually published something similar, and he said, you know, we see a lot of pulmonary clots right on the admission CT. And if you did a venogram at the same time, you don't find DVT in very often. So again, suggests that perhaps these two diseases are not necessarily related. So we suggested that we might modify the traditional trauma, triad. So there's stasis, as you know, and there's a hypercoagulable state and endothelial damage. And when you put the trauma patients on there, those that are paralyzed by their spinal cord, or because we give them paralysis and keep them on a ventilator for a long period of time, have the stasis. And if you have multiple transfusion, you might become hypercoagulable. And if you have a venous injury or a fracture, then you will have an endothelial damage. So we decided that this was what the trauma triad would look like. And in a subsequent publication that we said, well, maybe it's really a square. And there's stasis up here, and there's hypercoagulability up here, and there's this endothelial damage, but there also might be inflammation. And so we just said that perhaps it's more of a square, actually, than a triangle. I'll try to make this move here. So, no, that one I want. Go back. Oh no. Make it go back. Okay, there it goes. Go back. No, go back to the military one. Backwards, not forward. Please. Okay, so many of us have the great fortune to be able to work with the U.S. military, and we had an exchange program between the civilian trauma surgeons and the military surgeons at Landstuhl Regional Hospital in Germany. So we had an opportunity to observe the casualties that were coming out of Iraq and Afghanistan. And I went over there with my ultrasound machine because I always traveled with it. And I used to scan all these people when they got off of the airplane coming out of the desert. And we found a whole lot of DVT, as you might imagine, because there were lots of amputations and there were lots of blast injuries. And because these patients were going to go on from the ICU at Landstuhl to the U.S., they got CT scanned as well. And we found lots of clot in their lungs. And many of them were completely asymptomatic. And the military surgeon said, well, geez, are these PEs, and do we have to treat all these? Because you can imagine putting an injured troop on an airplane for another 12 hours as it took to get from Germany back to wherever they were going in the States. With a lot of downtime, and are you going to coagulate them for that trip? And they have a lot of injuries that could still bleed because they were still in their very acute stages. So they actually brought up the subject: do all pulmonary clots really need to be treated? So this was exciting to me. This is going to drive me nuts. Pam, is it easier for you to advance? Is it faster for you than this thing? Okay, let's stop there. So we, over a series of meetings, the CLOTT group got together several times, and I can tell you that this research grant was written 4 times by me. I almost gave up after 3, but eventually we were able to get funding through the Comprehensive Care Research Program, which we very much appreciated. And our main hypothesis was that that peripheral asymptomatic pulmonary thrombi, which we call PT, seen on chest computed tomography, can be safely observed. And the second hypothesis was that the risk factors for PT would differ than the risk factors for true pulmonary embolism associated with DVT. And then finally, on the third hypothesis, which is CLOTT2, is that patients who develop a hypercoagulable state detected by fibrinolytic shutdown, which I'll talk to you about in a minute, will be at increased risk for PT, PE, or DVT. Okay, next slide. So these are the 17 CLOTT centers across the country. You can see that we're well distributed, so we're east and north and south and west. And I very much appreciate all of you in the room who have been contributing to this large study. Next slide, please. So CLOTT Part 1 study is closed now. The study, as you can see, was prospective but observational study. So with the main outcome measure being the presence, location, and timing of any pulmonary clot, and the secondary outcome being DVT. We defined PE as DVT plus the pulmonary clot, and those that had no DVT was de novo PT. We specifically designed a CRF, or a data collection set, which we spent a lot of time on. It's 16 pages long. There is tremendous amount of data in there because we were anticipating that there would be multiple studies that would come out of this. So we collected demographics, mechanism of injury, and all the things you would imagine, and including transfusion data, but we particularly looked at their prophylactic measures, when they were applied, how many missed doses were there, why were the doses missed, why was a CT scan, were they symptomatic? We collected a duplex, obviously, for looking for DVT and any complications. So the data set is really really extensive, with a lot of drop-down menus. If you had more than one CT scan, we collected all of that. And the clinical researchers who were paid to do the study at each of these centers, that's what the money was spent on, had to go through training. We had webinars for them. We really were very, very careful that they knew how to use the data sheet. It's stored electronically in REDCap, which is located at the University of California. And now we have data use agreements with everybody, so not only can I look at everybody's data, but now everybody can look at the data themselves. This is sort of interesting for those of you that are designing research, maybe some of my younger partners and younger people in the room. When you do a DUA, you have to be sure that not only you can export the data to people, but that Hopkins can look at Harvard's data and Stanford can look at youth, which we didn't really anticipate when we did this, so we had to backtrack a little bit, but now we're in compliance, thank goodness, because I don't look good in orange, if I get arrested. It is DoD-funded data, so we have to be very careful. So the study design, as I said, was observational, so that if you saw a clot, you were allowed to treat it however you wished. Remember that when you do research for the Department of Defense, it has to apply to combat casualty people, so that you have an age range of when you're deployable. So we had to limit it to age 16 to 40. This makes a very big difference. So be very careful when you listen to what I'm going to tell you, because it's young people that we're talking about. And we wanted them to be at least in the hospital for 48 hours so that they had a chance to develop a clot. And they had to have at least one of the risk factors that we had previously identified in our 2004 study. So they're listed here, and you'll recognize them as, we didn't make these up, but we showed in our prior study that these were, in fact, the ones that were associated with VTE after injury. We defined a major operation as one that lasted at least 1 hour and that had to have anesthesia for it. So they weren't just getting a washout. And the rest of these you'll recognize as being very common among our trauma patients. So CLOTT 1, we have almost 8,000 patients in the database, collected over a period of 2 years. The DVT rate, again, most of us were not doing surveillance. Some places were, but the DVT rate overall was 3.5%. The PE rate was only 0.5%, but PT, isolated PT, was present in 1.5%. We were able to show that the factors that were independently associated with PT and not DVT or PE were the presence of shock on admission with an odds ratio of almost 3 and a major chest injury, which we had shown before in our previous retrospective study. So of the 117 patients who had a PT, half of them had a clot on the same side as their chest injury, which I think is very significant. These are the locations of the ones that were seen. There's a number of them that were just in the subsegmental. And about a fourth of the patients had these clots present on the initial CT scan. And the factors associated with those are, again, a chest injury and also a major venous injury. But again, we felt that if you had a PT on admission, it was very unlikely to be embolic by that time. And these were probably primary PT, related to the nature of the injury. I don't think this is going to project very well, but this is the proposed algorithm that we felt at the end of the paper we should be utilizing. It basically says that if you have a clot related on a CT scan with no symptoms, then you should scan the legs. And if you have no proximal DVT and you're not symptomatic, it's perhaps just wise enough to keep them on prophylaxis and not full anticoagulation and follow them carefully. Obviously, if you have clot there and you have a proximal DVT, as Dr. Gertz pointed out to me when we started to write this paper, that those obviously need to be treated. And you're going to see in a little while a better look at this from Dr. Cornbluth, and we would like to see the study prospectively, and hopefully some of you in the audience would like to help us out with this. But that was our proposed algorithm. And if it's easier for you to look at these visual abstracts, we basically said this was our study population, these were the methods, and these are our outcomes. And we felt that de novo PT are very distinct from the traditional VTE paradigm that we've always been talking about since the days of Virchow. So, and now I'm going to talk a little bit about CLOTT2. The difference between CLOTT1 and CLOTT2 is we're using the same exact database for that, but we, in addition, the patients who were enrolled in CLOTT2 had to be in the intensive care unit, and we chose centers that had active research groups that could collect blood samples for us and get some of these analysis done. So let's go back to talk about the trauma-induced coagulopathy. We know that acute traumatic fibrinolysis is associated with a very high mortality, and in fact, it has led to the widespread use of TXA, even TXA in the field. But on the other side of the equation is a failure to lyse a clot, and that has been recognized to increase mortality by 5 times. This is also very common, I'm just going to say, in patients that have COVID, that they have failure to lyse clot and have microclots all over their body. So some of this work came from Denver, who is one of our partners in CLOTT2. So fibrinolysis shutdown is actually not a new concept. It was first described in 1964 in surgical patients. It's been associated with myocardial infarction. It's been associated with postoperative hip surgery. Shutdown in those patients was also associated with VTE. And as I mentioned, COVID-19 patients have shut down, and that has been associated with not only VTE but also renal failure. There's a hypothesis, and came from way back when, that there were increased levels of plasminogen activator inhibitor 1 in patients that had fibrinolytic shutdown. And the most severe form of fibrinolytic shutdown is resistant to TPA. So we called it TPA resistance, and we can actually measure this in the laboratory. So the patients that were enrolled in CLOTT 2, the purpose was to describe the injury patterns associated with early shutdown and TPA resistance. And we hypothesized that early shutdown and or TPA resistance, the most severe form of shutdown, would be an independent risk factor for the development of post-traumatic VTE complications. So the prospective observational study, again, at 5 of the CLOTT centers, and they're listed down here below. Again, these patients had to have a VTE risk factors, but they also had to be sick enough to get into the intensive care unit. And we had paired samples of TAG assays with standard kaolin, as well as a special assay where TPA has been added. And they had to be paired samples at 12 hours and 24 hours after admission. And these were the definitions of shutdown and TPA resistance that we utilized. And because we were really looking for CLOTT, again, we were doing surveillance just to find it, but we were doing surveillance to see it as part of this research study. Each of these patients got a duplex at day 4. So we found 141 patients in the first analysis with the paired samples at 12 hours and 24 hours. And you can see that about half of the patients had shutdown at some time. Really surprised us. The other thing that was interesting, which is not really in the paper, is we saw people go in and out of shutdown. So they were initially in it at 12, and then they were back in normal at 24. Then we'd see them go back into this, and some of it might have been related to repeated trips to the operating room or something that we were giving them. But it was very, very common. I was really actually surprised at how many people had this hypercoagulable state so early. We found that the factors that were associated with early shutdown, it shut down not fibrinolytic, fibrinolytic shutdown, but not TPA resistant. So the two different entities were those that had been transfused more than 4 units of fresh frozen plasma in the first 24 hours, those with brain injury, as we've talked about already, or pelvic fractures, and those that had required an operation on their first day of admission. The factors that were associated with early TPA resistance, the most severe form of shutdown, were again those that had been transfused and those that had chest injury or long bone fractures. So the DVT was found in 15 patients, pulmonary clots in 5, one that had both, with an overall VTA rate of 14.2%, which, as you will recognize, is quite high. And we did find that TPA resistance at 12 hours was an independent risk factor for VTE with a hazard ratio of almost 6. So talking about when to start your prophylaxis in these type of patients, I'm saying 12 hours would be a reasonable time. So we concluded that patients with injury patterns associated with early TPA are at high risk for VTE. In these patients, prophylactic measures could be started earlier. As platelets are one of the sources of PAI1, the consideration should be given to an antiplatelet agent as a prophylactic measures, perhaps added on to your enoxaparin. The timing of initiation of prophylactic measures, in my mind, may be even more important than the agents that are used. And TPA resistance for the first time is a potentially modifiable post-injury risk factor for the development of CLOTT. And again, if you like these visual abstracts, which I'm not very good at doing, so somebody else has to do my artwork for me, but sometimes it's a little easier just to read it like this. Thank Hunter Moore for doing that one for me. So we do have this incredible database of almost 8,000 patients. And when you do research that's funded by NIH or the DoD, it's your obligation to share the data. once you've collected it. So we have a number of secondary analyses already going on in the CLOTT1 data. We have a weight-based enoxaparin dosing was presented at Western Trauma Association, and so that's already been discussed here. Two abstracts that have been accepted now for the AAST. One is Todd's that talks about using early thromboembolic prophylaxis in patients with spinal cord injuries, which demonstrated that it was important to do it early. Also, the solid organ injury, and I'm sorry, Morgan, it's a little bit more patients than you had in yours. So we are now becoming the largest study to talk about and we used AISF3, so we don't have any data on low-grade spleen or liver injuries. But this is again, early prophylaxis does not increase the chances of non-operative failure. So those two will be presented at the AAST, that's actually here in Chicago. And Elliot has a number of CLOTT papers related to missed doses and the reason for that, and I'm sure he's going to talk to you about that in his time, so I'm not going to go through those. We've also got a number of other planned studies. We have a total of 15 now that are in some form of being looked at. We're looking at vena cava filters, which most of us don't use and have never advocated for, but some centers do across the country. So there's somebody looking at those. There's prophylaxis looking at head injuries. Remember that all of these 8,000 patients were enrolled prospectively. So these will be a huge number of prospective studies coming out of CLOTT. We're looking at head injuries. Matt Martin is looking at enoxaparin versus heparin because a lot of centers did use heparin. There's an orthopedic predictive tool. Our orthopedic colleagues know about this. That has been studied at Southwest. They want to see if that predictive tool works for general trauma. There's some people looking at complications of early prophylaxis. We're going to look at TXA administration and how that relates to the VTE. And Dr. Kornblith, who's with me, is looking at the platelet biology in those patients that were enrolled in CLOTT2 and have all that data that was collected on blood samples. And we also doing some assays of plasma assays that are ongoing, looking at TPA and PAI and some of the other important aspects in the plasma of people. That's going on in Denver. So there's lots coming out of this. I'm going to make one final comment, and I probably won't be real popular with this, but I'd really like to change the terminology that we use so that we're all talking about the same thing. I think that the whole concept of VTE should kind of be retired, at least in the trauma patients, because most of the clots that we are looking at are really not embolic. And those that do embolize, they lodge in the pulmonary artery, not the vein. So that's why I give a venous thromboembolic. This doesn't sit well with me. If I remember my anatomy right, these are in the artery, not in the pulmonary vein. So I would like to propose that DVT should be changed and it should be only used to say deep venous thrombosis. So when you're really looking at the veins, and PT should be used for primary pulmonary artery thrombosis, and PE can be used for those patients that have both. So that we're all really talking about the same thing when we're speaking about this scientifically. So finally, I would just like to maybe garner your interest in a prospective study that Dr. Neal and Dr. Kornblith, who's here, are going to head up for us. And this would be looking at, again, this is hard to read on the slide, but we will give you a copy of it, basically saying that if a patient has clot present on admission in their chest CT, their very first chest CT, and they're not symptomatic, recommend that they get a DVT ultrasound for proximal DVT. And if they don't have that, then they should continue on prophylaxis doses and not full dose, versus those that would go on to full dose if they develop symptoms, or if they have a DVT that you can see on their first admission. So we are looking basically at compliance with this. It would not be a funded study to begin with. It's an experiment that would collect data from a few centers so that we have some basis of which to go after some major funding to get this to be a national study. So we have for you the primary outcome would be the equivalence, basically, of these two different protocols, and the second would be to look at compliance. And we will obviously be collecting data on progression, VT recurrence, mortality, all those things. So if you're interested, we do have at the bottom of this. Well, no, this is my retirement plan. My bike and my wine. But this is a QR code if you are interested in helping us out with this. We're looking for volunteers, and it's not a lot. We're not going to make you collect 16 pages of data like we did for CLOTT 1 and 2, but it would be relatively simple. We wanted to get this out of CLOTT 1 when we proposed this, and remember we allowed people to treat clot that they saw on pulmonary scans any way they wished. And, you know, despite all of my preaching, a lot of people treated clot as CT as if it was pulmonary embolism, and they got anticoagulated or filters. And I personally look at every single one of those patients that was in that database. And I was just talking to some of my colleagues and to Dr. Gertz. It's really important when you're doing a large database, for those of you who are young and are going to get into this, to really roll in your data. Don't just say what the statistician told you, because, you know, they don't really actually look at the patients. They're just looking at numbers. And it's really important to understand every patient that you're putting in there if you're going to describe these things. So I think, again, as I looked at it, nobody got worse as we looked at those patients that didn't get full dose anticoagulation, but we really need a bunch of centers to agree to want to look at this in a careful way. So I will open it up for questions or criticisms, or, you know, not tomatoes like, you know, what the name was worried about, whatever that president was before. But happy to entertain questions or suggestions or how we might go forward. And hopefully there will be interest enough in the secondary studies so that we can get additional funding to continue into CLOTT 4. Thank you.
I have a quick question for you. First of all, congratulations. I mean, an incredible amount of work, and it shows, I think, the power of building a multi-center group that works together collaboratively and iteratively, you know, evolves the field. So just incredible. My question relates to the fibrinolysis shutdown study. It looks like you had a relationship with the TPA resistance, but not for fibrinolysis shutdown as we have sort of traditionally defined it. So I'm curious as to what your thoughts are about that, and also what proportion of the patients actually had the more severe form of TPA resistance over the, you know, high rate of fibrinolysis shutdown by the definition that's used.
Yeah, so these are a very small subset of all the people that are in CLOTT 2. And we collected data for a week on these patients. So there were 7 different time frames, and so we haven't looked at all of it. We just were looking at the early markers because there seemed to be a signal there. But there's a lot more there that needs to come out in the rest of the papers. And we can't, you know, so this TPA resistance is a, how can I put it? It was an experiment that was designed in Denver where they were looking at fibrinolytic shutdown, and they started to do these assays where they added TPA. It's not commercially available, and actually your new hematic machines won't even let you do it, right? You can't add different things into the machine like you could do on that 5,000. But it is, you know, it is a pretty interesting stuff, and we thought at least if we identified the patients that were likely to get it, people could use it that way. and most of you are using TAG anyway, but this was a sort of a specialized TAG that I thought it was pretty interesting, and it did fit in to our hypothesis that early patients would be at significant risk. So, yes, AJ.
That was excellent. Enjoyed it a lot. But the prospective study you are suggesting with Lucy, what does the preliminary data show, since some of these people in your CLOTT group were treated and some were not treated? I think you hinted it towards the end, but what does it show? Is there any difference?
So the patients that were not treated, they were fine. I personally looked at every one of those, but I didn't tell Elliot how to treat his, or or Todd how to treat his, and so they were all over the map of how they were treated. But the ones that were not treated, and there was a small subset, they were fine. They did fine. But we can't, there's not enough to say that so it's really, we need a safety study, to be sure.